Good afternoon. This is the second presentation about the changes that are going to happen as of January 2021 to the Evaluation and Management Office Visit Codes. In the first presentation, we talked about the changes happening to the medical decision-making part, and in this presentation, we'll talk about some of the changes that are happening to time documentation. First, I'd like to clarify a few things. When we say office visit E&M codes are changing, what do we mean by that? We mean that the documentation needed for new and established office visits will change as of January 1st, 2021. So the code number, or the number that refers to a certain level of office visit, is going to stay the same. What will change is how we account for such a code, what documentation we need to get such a code. Specifically, one code is disappearing, 99201 is going away. It wasn't used anyway, but it's now going to be obsolete. 99202 to 99205, which are the new patient office visit codes, and 99211 to 99215, which were the established patient office visit codes, will stay, meaning the number itself or the code itself will stay, but what we document to get these codes will be completely different. Office consultation codes are staying the same, and hospital visit codes are staying the same. So the changes in documentation required is only limited to the new and established office visit codes. In a nutshell, the changes in documentation needed is going to fall under two categories. From January 1st, 2021, the visit code will depend on only two things. Medical decision making, we talked about that last time we had a presentation, and in this presentation we'll talk about the second part, which is time documentation. So the time documentation changes are basically four. Number one, typical time will change to range of time. I'm going to explain each one of those items, but first let's see what they are. Number two is requirement for counseling and coordination, more than 50% is gone. Number three, face-to-face time will change to total time on the day of the visit, and prolonged codes will become more realistic. Don't be worried if you don't understand what this means. I'm going to explain them, but I just want to explain that I arranged them from the least impactful, the least significant, to the most significant, most impactful on our practice and day-to-day clinic workflow. Let's start with the first change. Currently, when you document based on time, you would say something like 25 minutes were spent in a face-to-face encounter and 50% of the time was spent in patient education and coordination of care. You're saying that because the Center of Medicaid and Medicare Services had determined that a certain amount of time is typical or is reasonable or is expected for a level 4 visit. So that's why you use the number 25. Now that will change as of January 1st, because instead of a typical time, we will get a range of time. But I'll show you how that in a way affects what we do, but in another way will not change much how we document. Here is what the current system has. From 99202, I put the new patient codes first, and then you have the established visit codes, and it has the typical time that is expected of you to write in the documentation for your time with the patient. But as of 2021, that is going to be arranged. So for example, from 2021, instead of using 20 minutes as a typical time for a level 2 new patient visit, it's going to be between 15 and 29 minutes. Now, it goes by 15-minute increments, as you can see here, for new patients. But for follow-up or established patients, it goes up by 10 minutes each. So that leaves us with a question. What are we going to write in the note? Are we going to write that I spent between 15 and 29 minutes with the patient? Actually, it turns out that the Center of Medicare Services does not want you to write that, because you did spend a specified amount of time with the patient. All right, it may be 20 minutes, maybe 22. You don't have to be extremely accurate to the time. You definitely do not need to keep track of the exact minutes and seconds you spend on an encounter, but you need to be writing a specific time. And that is why I wrote in between parentheses the number of minutes that will get you that level if you were to use documentation by time. For example, here in 99202, the current system wants you to write a typical time of 20 minutes, but for the new system, I put in parentheses 15, meaning that you can use 15, you can use 20, you can use 25, anything in between 15 and 29. It has to be a specific number between 15 and 29. For simplification, I put it at 15 and going up by 15-minute increments for the new patient visits. And for simplification as well, I started at 10 for the level 2 established visit, going up by 10 minutes for each level above that. I hope this is clear. The second time documentation change, which is a little bit more significant, is that the requirement for counseling and coordination of care more than 50% is gone. So what's that about? Under the current system, you had to spend more than 50% of the time in counseling and coordination of care in a face-to-face visit with the patient. Well, a couple of problems were present with that system. Number one is we could argue ad nauseum what is counseling and coordination of care and what counts and what doesn't count. The second thing is that having that requirement tends to ignore things that doctors and allied professionals do all the time that they spend a lot of time in, as reviewing documents, preparing to see the patient, coordination and calling other physicians, having, documenting even things in the medical record that consume a lot of time but are not accounted for because they are not a face-to-face, 50% counseling and coordination. So what to do with that? They decided to remove that requirement, and so from now on you don't have to write counseling and coordination is 50% or 60%, and you don't even make any mention of that, nor should you need to. The third item is that face-to-face time will change to total time on the day of the visit. Again, going back to that recognition that a lot of work, a lot of care gets done without being face-to-face with a patient. If you have to review a lot of documents, a lot of labs, a lot of radiology images, you have to do that prior to seeing the patient. Maybe you look at the images on a CT scan or ultrasound. All of that takes time, takes effort, takes mental work, but is not face-to-face. So that is why all these things that happen and that you do to care for the patient are included in the total time of the visit. And so you account for the total time you spent either preparing to see the patient or during the visit in education, talking, discussion, answering questions, putting orders, reviewing things, or even after the visit in communication with other providers about the patient, or in documenting even the changes that you did and documenting your note in the EMR. Now that takes time and adds up, but the only caveat to that is that it has to be all done on the day of the visit. So anything that you do on a different day would not count towards that total time. It has to be all on the day of the visit. The fourth change is that prolonged codes will become more realistic. And perhaps this is the most impactful or significant change that's going to happen to time documentation. First, to understand this, we need to understand what's the current system and what are prolonged codes exactly, how are they accounted for. So currently there are codes that you could use in case you spend prolonged period of time with a patient. 99205, for example, the typical time for it is considered to be 60 minutes. That's a level 5 new patient visit. The typical time is 60 minutes, but in order to get that prolonged visit code, you would have to exceed that by 30 more minutes. So if you spend 90 minutes with the patient, you would account for that by adding 99354. If you spend 135 minutes with a patient, then you can add 99354 and 99355. Now, I wasn't even aware that we had those codes currently, and frankly, even if I were aware of their presence, I probably wouldn't use them all that much because of the length of time that is required, that is needed. 90 minutes for a new patient, that's a lot. 135 minutes for a new patient, that's a lot of time. Same thing for established visits. To get that 99354, you would have to spend 70 minutes with an established patient, and in order to get 99354 and 55, you have to spend 2 hours almost with an established patient, which is just not realistic, not practical. So how did these codes change? We'll see on the next slide. As of January 2021, the code will be different because between 60 and 74 minutes spent with a new patient, that is the 99205, which is level 5 new patient visit. Between 75 and 89 minutes, as you can see here on line 2 of this table, that gives you 99205, and you add to that 99xxx, which is 1 unit of prolonged visit time. Those units, all of them go by 15-minute increments. So any 15 minutes and every 15 minutes above the upper limit for a level 5 visit, you would get 1 unit of 99xxx. I know this can be hard to understand, but I will help you with 2 different ways. One is I'm going to do a timetable that I think you'd find helpful. We'll see it in a couple of slides, but also where it hits home is where we do the cases and we can see how we can apply this in real life. So the same idea applies for established patients. So every 15 minutes above level 5, which is 99215, every 15 minutes beyond that gives you a unit of 99xxx. Let's clarify by seeing more slides about the same topic. Just to remind you again that the medical decision making is going to be the main way of establishing the visit code. Time documentation, which we discussed today, can be used and should be used in some instances where you're spending more time with the patient than the medical decision making can give you a code for. And we'll see that in case examples. So, new patient time documentation starts at 15 to 29 minutes for level 2 new patients and goes up by 15-minute increments till 60 to 74 minutes for level 5, then 15-minute increments for each extended or prolonged service code 99xxx beyond 99205. the established patient documentation starts at 10 to 19 minutes for level 2 and goes up by 10-minute increments until the highest level is level 5, where you can get that by a time range between 40 and 54 minutes. Then 15-minute increments for each 99XXX interval beyond 99215. Now, I made a table to make this easier for you, and I hope that you can have it even in a laminated card or a printout, because that table will probably be the easiest way to remember what we just explained. This is the table, all right? I put here new patient, how many minutes are required as a threshold, or as at the least minimal amount of minutes needed to get time documentation for a code. 15 at least gives you a code of 99202. 30 at least gives you 99203, and so on. So to simplify it, wrote it here is 15, 30, 45, 60, 75, 90, 105, all going by 15-minute increments. And you see here that you can get, if you spend 105 minutes in a new patient visit, you can get 99205 plus 3 units of prolonged visit code, which adds up a lot to your work RVUs. Established patient visits. The time in minutes starts with 10 minutes for 99212, and each 10 minutes above that can qualify you for a code higher until you get to 40 minutes for 99215. Then from then on, every 15 minutes can give, above that, can give you an extended visit code until you can get 99XXX times 3 plus 99215 if you had an 85-minute established visit, that you did. So let's go to the final slide and see the summary of all what we discussed today. In summary, typical time will change to range of time in time documentation. Requirement for counseling and coordination of care being more than 50% or dominating the visit is gone. Face-to-face time will change to total time, but on the day of the visit, and prolonged codes will become more realistic. Finally, E&M visit codes should be mainly by medical decision making. Just to reiterate this very important point, use time documentation sparingly, and we will see some examples in some cases where that might be the case. You will need to use it when the MDM does not give you enough level of visit of a code. Let's say, for example, you spend a lot of time in counseling the patient, in answering questions. They bring you a lot of questions from Google or the internet that they want you to answer. And you spend a lot of time answering. Now, at the end of the visit, well, you didn't establish a new diagnosis, you didn't prescribe a new medication, so you may not be able to charge for medical decision making level 5, for example, but you did spend 45 minutes with that established patient, which qualifies you for 99215. So I hope that makes sense, and I hope that you would ask any question that you want in the comment section. Please don't forget to share, like, and to comment in the comment section. And if you have any questions beyond that, you can email me, and I'd be glad to help you. I hope this has been clear, and I know that we're going to get more clarity when we discuss typical cases. Thank you. Have a good day.